are some of the challenges that we have with kids with HHT. And the first one is, how do we diagnose asymptomatic children who may be at risk for organ manifestation? Because as I will go into, in pediatrics, it isn't always the case. So it's actually quite common that these children are completely asymptomatic. What are the best screening tools? And we have adopted most of that from experience in adults, but over the years we have gained some experience on how to best to do this. And then finally, how do we raise awareness? Because there's still a lot of unknown, cases of HHT that we encounter, and it's important that our pediatric colleagues also know about it as a potential cause of some of the manifestations that can arise. So you're all familiar with the HHT clinical criteria, the Kurosawa criteria, and I put the Kurosawa drink next to it. So which is epistaxis, telangiectasias, visceral ABMs, plus a family history. But, and genetic testing is actually currently not part of the criteria, and that's from a pediatric point of view, a bit of a problem, because we use genetics basically as our entry into the diagnostic process. So it's a bit, but there are some differences between centers of how this will be done. But I will explain a little bit more on how we approach this. And many of the symptoms that are listed here are not necessarily there in kids, and especially in younger children. So it's important that we make a diagnosis even in the absence of that. And often the only thing that we have is just a positive family history. And with that, we would never be able to make a clinical diagnosis. So this is an old summary in the New England Journal of Medicine 25 years ago to say and that reflects the knowledge at that point in time of HHT in children, and some of that is still applies. And basically, nosebleeds is what is said there is usually the earliest symptoms with an average age of onset of about 12 years. If you say an average, so many kids can have it earlier than that, and some don't have it at that point. And 95% of them will eventually have it, and often the telangiectasias, the small blood vessels on the skin, can be subtle and absent, and that's certainly often the case in kids. So when we go back to our experience at SickKids in terms of HHT, that there was always the question, how much symptomatic cases do you actually see in children? And this was this first summary provided by Meir myself, who at that point was a fellow at SickKids and is now leading the HHT center in Israel for both children and adults. And he summarized some of the cases, which were 14 children with symptomatic HHT. 7 of them had pulmonary ABM, 3 cerebral or spinal ABMs, and the cerebral and spinal ABMs in children often present with hemorrhage due to the fact that the diagnosis of HHT is not made before. And one of the reasons why we really have to think about being more proactive in terms of educating our colleagues about this as a potential issue. And this basically demonstrated that symptomatic HHT can cause significant morbidity in children, as well as it is known to do in adults. So that then led us to the development of a screening program. And you can ask also, why should we screen? And here are some of the reasons why we feel strongly that we should screen. And the first one is that for intracerebral ABMs that Dr. Krink has talked about in greater detail just before me, much more elegantly than I can do it. And intracerebral hemorrhage due to ABMs can occur as an early symptoms in childhood. And pulmonary ABMs that can cause problems such as stroke-like episodes and brain abscesses have also been that has also been described in children. So this is not limited to adults, and we have certainly seen that as well. And then the spinal ABMs that are overall rare can cause hemorrhage and therefore significant problems. So what is the most common scenario that we encounter in our clinic? Well, that is that we see a child with a positive family history but when we look at this kid, at this child, there are no symptoms and no clinical signs. And our first step is then to do a genetic testing in what we call the index case, which is the affected parent. Because of its nature being an autosomal dominant disease, children have a 50% chance of having HHT if their parents have it. So, and while there are some new developments and what we call de novo mutations, the vast majority of them have an affected family member. And often we actually diagnose this through the children, that we have a symptomatic child, and then it turns out that one of the parents has HHT as well. So what we do is we do genetic testing of the affected parents, and in about 90% of the cases we can find underlying genetic mutation. And if that's positive, then we test the child to ensure whether, and then we can make that case to say either we can make the diagnosis or exclude the diagnosis if the genetic testing is negative. And that's very helpful as well, because we don't have to follow these children over time, and the parents know that given child will not have a risk of any of the problems of HHT. If it's negative for about the 10% of cases that we know where genetic testing might not be helpful, we still follow up these children similar to confirmed HHT patients, even though their risk overall seems to be somewhat lower, and I'll go to that in one of my next slides. So what do we use as screening tests? That will look very familiar to you, because these are also the screening tests that are largely done in adults. So the first is a brain MRI, which is the best way of really assessing for malformations in the brain. We clinically check the oxygen saturation, because this is a sign of a pulmonary ABM. And we looked before whether it's necessary to do this in two body positions, but have found that just an upright oxygen saturation is sufficient. And then we do a bubble echocardiogram, and I'll tell you a little bit more about this as a screening test, and a chest CT only if the bubble echo is positive. This is our first screening experience, and at that point in time, actually, we did both bubble echoes and CT in all the patients, because at that point in time, we didn't really know how useful the bubble echo is in children, which we have learned subsequently. So this is just breaking down so that the children referred to our clinic, and if we break them down, 55 of them had a potential but unconfirmed diagnosis at the end of the workup. And 61 had clinically and genetically confirmed HHT, and another 21 were already symptomatic with visceral ABMs. And of the ABMs of these patients, we could see that 15 of these patients where we made the diagnosis had either pulmonary or cerebral ABMs. So a significant proportion. So if we looked at just of this group of the 61 patients with children that were asymptomatic, in 46 of them, we made the diagnosis based on genetic testing, and in 15 they actually fulfilled the clinical criteria. So many more children in whom the genetic testing actually reveals the underlying diagnosis, and that's a specific issue for children with HHT versus adults. And if we look at the overall numbers again, about 25% of the kids were positive for ABM. So a significant proportion, and we therefore think that screening is important, because you can find abnormalities in a significant proportion of these children. The majority of them pulmonary ABMs, but also cerebral ABMs, and some of the unfortunate kids have both pulmonary and cerebral ABMs. And some of these kids were relatively young, so 8 of the 14 patients with pulmonary ABMs were younger than 10 years of age. So postponing the screening for later on may not be ideal, because we could miss those children. So how about the genotype-phenotype correlation? I won't go into greater detail into that. Many of you will probably know that there are 2 most commonly found genes that can cause HHT, the gene and the second gene, which was either called ARC1 or another name, but which I won't use. But if we looked at these 61 patients, they basically broke down into two groups, either having the endoglin or the ARC1 mutation, and the numbers were very similar for both mutations. But children with the endoglin mutations were more likely to have pulmonary ABMs. And that reflects the experience in adults. And if we look at pulmonary ABMs, it was actually, for this overall group, which also included the symptomatic kids, it was 70%. So how about the asymptomatic patients with an unconfirmed diagnosis, or where the genetic testing didn't really help us to clarify the diagnosis? So in 2/3, they had a clear positive family history, but the genetic testing was negative. The other ones, the family history was not so obvious in terms of whether it was clearly HHT related. The initial screening of these patients that we did was negative in all of these cases. So the diagnostic yield is certainly lower. But we still offer this screening tests in these children, just because we know that we would expect that in some of these patients, they actually have HHT, and because the genetic testing has an imperfect yield. But we discussed with the families that the likelihood that we find something is going to be lower, and but the majority of families that we care for still go forward and want to do at least screening at least once. So then the question, so how do we screen for pulmonary ABMs? And so the bubble or contrast echo has certainly been shown to be very useful in adults. And in the previous guidelines, and Marie will talk a little bit more about the new guidelines in this meeting. The previous guidelines didn't give clear recommendations for children because the evidence just wasn't there, because there was no published reports about how useful is contrast echo or bubble echo as a screening test in pediatric patients. And we looked at this, and I'm not going to bore you with all of these numbers here. This was done by one of my fellows looking at all our data, where we compared the yield for the bubble echo test with the CT in the same patient. And the only column that you really have to look into is the one for sensitivity, which is the third one. And you can see the sensitivity of the contrast echo in this series was 100%, which is perfect. So we can say that if we use the contrast echo as a screening test, we won't miss any cases of ABMs. The specificity, also how likely is it that if you ever do the test and it's positive, that it actually reflects ABMs, is not quite as ideal. And you can see it's a little bit age dependent. But so if we have a bubble echo, we would then do a confirmatory CT. But using the bubble echo as a screening test, we can reduce the number of CT assessments that we need to do. And we can use additional criteria on the bubble echo. And I'm just showing you one of them that another student of mine has looked at, which is if you look at the number of cycles after which the bubble echo is positive. So what you do with the bubble echo, you agitate saline, then you inject it into a vein, and you wait how quickly it can come up on the left side of the heart. And the shorter the time interval, the more likely it is that you have significant ABMs. And if we look at those requiring interventions, and then we could see only those with 5 or less cycles were those where we found CT imaging subsequently, ABMs that was significant enough to require treatment. So we can zoom in a little bit more in terms of how many CTs we actually need. So another question that we were interested in addressing is this, because there's this overall notion that ABMs and similar to other symptoms of HHT would certainly become more prominent over time. such as nosebleeds, are the pulmonary ABMs actually more common in adults than in children? Because when we looked at our initial series, it wasn't so much different from the ABM frequency that was reported in adults. So what we did is we looked at the children with HHT and specific mutations and compared them to their parents because they have the same genotype, right? So, and if you just look at the first column, which is those patients with endoglin mutations or HHT1, you can see in this series that with 60% of the children had pulmonary ABMs, 67% of the parents had ABM, and this is identical with an overall series of what we find in Canadian adults. So this really, so we had less numbers for the ARC1 mutations or HHT2 or for another mutation that I'm not going to go into, SMAD4. So we can't really say too much about this, but it certainly raised the question for us, is it actually the case that these ABMs form over time, or are they all preformed at birth and just grow over time? And that, if that was the case, and if we knew that, then we could say we don't actually need to rescreen for negative patients. I don't think we have a clear answer to yet, and there are certainly reports that new ABMs show up on imaging over time. But we can certainly say that likely the majority of ABMs are present early on and likely preformed at birth. So what do we do in terms of rescreening? And I already mentioned that if for those with initial screening results, the yield in our hands hasn't been very high. And we reported about this 6 years ago, and we're actually looking into that again, just because if you have larger numbers, you can be more sure about it. But when we reassessed the patients with initial negative screening results on rescreening, we found no pulmonary ABMs and no brain ABMs. And that certainly raised a couple of questions in terms, should we rescreen, but also should we extend the screening intervals, which we currently do every 5 years. We haven't completely changed our strategy yet, but it's certainly something that might happen in the next little while. Here's some of the more updated rescreening data, which was done by a Scottish student who worked with me in 2018. And this is based on looking at 300 patients now in our database. And I'm not going to go into all the details of that, but the important part is really for the rescreening here. These are patients, and I'm just focusing on those that had initial screening and then had at least one rescreening. And when we looked at this for pulmonary ABMs, all of the ones that were negative at initial screening also were negative at the follow-up screening. When we looked at the next interval for screening, the numbers become a little bit lower. There was one patient who had a questionable ABM, but it was so small that it didn't require an intervention. So still an ongoing question that we try to tackle over time. The other question is about the growth of ABMs, because it is not an unlikely scenario that we find smallish ABMs in children. And then it's always the question, if we look at them over time, do they grow? And how often should we look at those in terms of deciding whether at some point they require treatment or not? And this was actually a study that was done by my daughter. I'm always proud of my daughter if she does work, and especially if she does a study related to HHT. So she looked at a group of patients that had small ABMs on the initial imaging, but that didn't require treatment, and looked at the follow-up imaging over time to see how quickly do these ABM change over time. And I show this graphically, and you can see there's quite a bit of variability. So it's not the same for every individual, for every patient. But overall, you can see that there's a trend for the lines to go up. And if we look at the mean change over time, then we can say that for a group overall, pulmonary ABMs tend to double in size over a period of 5 years. And that's actually the screening interval that we use. So that might be a reasonable time interval to use. So how about brain ABMs? So this is our experience reported a number of years ago, 11 children with brain ABMs. Unfortunately, 6 of them presented with cerebral ABMs. And when we looked back, most of these kids actually had a positive family history or a symptom of nosebleed. So they could have been picked up before the bleeding event. And so this goes back to the point of really making sure that we increase the knowledge in the community about HHT so people think about it and refer patients early on. How about liver ABMs? They're certainly common, but symptoms in children are extremely rare, and so they can cause high output failure and other issues. So screening in the past was not really recommended, and we haven't done this. With the new guidelines, there's a push towards screening for liver ABMs as well. And so we would, so since we want to adhere to the guideline, we will also start screening for liver ABMs in children. But there's a specific form that we learned about, and actually were the first to report on at SickKids, which is symptomatic liver ABMs in neonates. And we had a series of newborn babies that presented with high output with heart failure, basically, which is not a common symptom in a newborn. And the reason they had heart failure is because they had big ABMs in their liver. And usually you don't do interventional treatment for ABMs in adults, but in those kids, we used interventions, and some of them successful in terms of occluding the ABMs. And we have now some patients where we have followed for up to 10 years with no recurrence of these liver ABMs. So they may behave somewhat different in children than they do in adults, but the experience is certainly relatively limited. So let me just finish up with some of the recent guidelines for HHT, and I'm not going to talk about the guidelines overall because I know that Marie Faunen will do this in more detail, but during this meeting. But I just wanted to highlight some of the points of the pediatric guidelines where we try to answer a couple of questions related to HHT, and this was really an international effort with people from many continents and many countries, and I had the privilege to co-lead this with Hans-Jürgen Mager from the Netherlands. And we tackled a couple of questions, and the first question is genetic testing indicated in asymptomatic children of parents with HHT. I told you that's what we do, and this was also what we agreed upon in the guidelines, that the expert panel advises that diagnostic genetic testing should be offered for asymptomatic children of a parent with the HHT. It should be offered. It's not that we absolutely feel that it needs to be it is still the family's decision whether they want to do it, but we would certainly offer it, and the majority of families are certainly moving forward with that. When should asymptomatic children be screened for pulmonary ABM? So we agreed that we should screen for PABMs and for these pulmonary ABMs in asymptomatic children, regardless of age. So we shouldn't wait years and then screen. We should screen them as soon as the diagnosis is made. Sorry, and I'm not going to go into the details here. I'm just going to focus on those specific questions. Then the question, do we need to treat all pulmonary ABMs in children, and what should be the follow-up? And the recommendation was that all of those that are associated with a lower oxygen saturation, which we always measure in the clinic, should be treated to avoid serious complications. And when should we repeat screening? The current recommendation is that we should repeat screening after 5 years. But as I mentioned before, the exact interval is might be something that could change over time for those where the initial screening has been negative. And moving to the brain ABMs, do we need to screen children that are asymptomatic for brain vascular malformation, and at which age? And we came to the similar recommendation that it should be screened. It was worded a little bit differently because there were some differences between centers, and some centers in Europe and North America. I think in North America, we are pretty on board with screening all children anyway, but and so it was worded that it should be a shared decision between children, parents, and the child. And I think that's actually always the case. It should always be a shared decision of whether we do screening, but we strongly recommend it. Do we need to treat asymptomatic brain vascular malformations? If they are larger, yes, they should be treated, and we agreed on that. So, this is kind of a run through, through the current model of care for HHT. But we certainly have a number of open questions that we hope to be able to answer over time, and so we keep an ongoing database to really understand and to understand some of these underlying issues and to be able to answer those questions. So one that I already mentioned, are most or all ABMs preformed at birth? Should be therefore, and because that could certainly affect the frequency or need of rescreening. And then the screening for liver ABMs is still a bit unclear how useful it will be. And one thing that we don't screen for are spinal ABMs. They're very rare, but if they are there, they can certainly cause significant morbidity or significant problems. So it's been a bit of an open question whether we should or should not screen for that. And with that, I will just acknowledge a couple of people that work in our center and refer you to our website if you want more information about HHT in children. Thank you very much. And please ask questions.
All right, thank you so much for your talk, Dr. Ratjen. It was very informative and I found it very, very interesting. And now I'll proceed to ask questions from the audience members. So our first question is, what precautions do children with pulmonary ABMs need to take?
Okay, so that's a very good question. So basically, the precautions are very similar to the ones that are used in adults, including using, whenever an IV is used, to use a filter, to use antibiotic prophylaxis for procedures. And I think it's really important to do that. Unfortunately, I must say that the antibiotic prophylaxis is not always perfect. We have seen some cases, patients that have significant, quite bad pulmonary ABMs, where despite the fact that the prophylaxis was used, they develop complications such as brain abscesses. But you can certainly reduce that risk, and so we would recommend that strongly.
Okay, the second question is, what age do you usually screen children with a confirmed parent diagnosis?
Okay, so once we know that the diagnosis of the parent, then we would start with genetic testing as early as possible. And sometimes this is done on cord blood, because we can use the cord blood to do the genetic testing on. Or we do just as soon as they contact our clinic, the first step is that we offer genetics testing. And the scenario isn't always that the parents have been tested as well, because often the diagnosis is made clinically. What we do in this case is we basically test the members and the families that are in fact affected. We are somewhat in a fortunate situation that the genetic lab basically for all of Ontario is at SickKids, and so for us it's relatively easy to proceed with the testing. I know for some centers it has been a bit more challenging to get the testing organized and get the results in a timely fashion.
The next question is, if there is an initial negative screening, are there any precautions that should be taken in regards to child until rescreening?
That's a good question, but our current approach is to say no, because we have no evidence that there's any likelihood of an ABM that cause problems. And while there is a small risk that something changes in the meantime, I think the risk is so small that we don't recommend to do any specific precautions. We hope these children can live a life as normal as possible without any restrictions.
Our next question is, if do you recommend that asymptomatic toddler patients with confirmed HHT should go to the hospitals for tests, given the state of pandemic right now?
Yeah, this is a question that is not just simply related to HHT, but overall, that if you always have to think about what is the risk benefit for diagnostic testing. The hospitals are actually, especially our pediatric hospital, is a pretty safe place because we have very limited HHT, and in children it isn't a major. We have very little COVID, and in children it's not a significant problem overall. Anyway, so I think our recommendation would be yes, but of course it's always a decision that each family has to make. And so if they feel very uncomfortable about it, then we say, okay, then let's wait. I must say, the vast majority of patients still come in and feel safe in a hospital, and I think they're right to feel so. But of course, it's always a decision that each family needs to make. And for the initial contact of families before we do we move into the screening procedures, we have now moved to virtual visits that we do via Zoom, like now, where we see the families remotely, and that is very helpful, especially since we have a catchment area which is very large and goes all the way to the Atlantic Ocean. So it's sometimes easier if we can do some of that as an initial virtual visit before we go into the details. And we can also clarify at that point whether the family actually seeks the care and wants the screening procedures to be done.
Thank you. The next question is, when a child is referred as a result of clinical family diagnosis and you do a genetic test of a parent that is negative and decide to proceed to screen the child and monitor, do you revert back to the genetic testing in case of genetic testing advancements?
Very good point. Yes, we do. The reality is, so the testing is already done with relatively advanced technology because it's whole genome sequencing, but there are new genome sequencing technologies. And one of the reasons we go back, because sometimes the genetic testing gives us a variant of unknown significance. So you have a genetic change that you don't know. Does it cause HHT? Yes or no? And that can change over time because there's no information coming into the database. And so this is where we also involved our genetic counselor, Ratjen, who will then check all the resources to see whether there's any new information that came in the meantime.
Our next question is, should kids under 10 years old with anemia and high ESS get screened for PABM?
Well, it's a bit of a question of what's underlying the anemia. So there could be so many causes, so you have to be a bit cautious of screening everybody. So I mean, what we do in unclear cases is that we get a thorough clinical history and also a good family history to see what the relative risk is, and then based on that risk we can decide whether screening should be done or not.
We have a few more questions. Is there or will there be a program teaching and requiring all hospital staff to be aware of and have knowledge of IV air filters, HHT?
Yes, I know this is a contentious issue because it always happens again that not everybody in the hospital is aware of that. But yes, we have gone through that in the past, and we will go through that again and ensure that. And we have mechanisms in place in our hospital if there are situations where this doesn't happen, and we do specific rounds to discuss it and to ensure that we learn from it and improve our care in the future. So.
Yeah, awesome. Lastly, are there any improvements over time in the genetic testing? Is it often a mutation of unknown significance can be upgraded to confirmed genetic cause?
Yes, well, and certainly that the evidence is mounting over time, because if you, and that's really where it becomes very important for all the centers to work together, because it is a relatively rare disease, but if you get the information from multiple centers, and then you can have situations where you clearly can link a mutation to HHT within a family, then you can change the annotation of that genetic mutation. And yes, so therefore that's certainly the case. In terms of the genetic technologies, in terms of screening, they also change over time. And where we talk about gene sequencing, there are now 5 or 6 methods for gene sequencing, and they change all the time. So you get more details with any new technology, but also some of the new technologies are rather costly. So it is a moving target, and so we have to keep up with that. And as new changes come about, and as new technologies come about, we'll have to revisit that.